And I want to see if you guys have any questions.
I
I'm gonna get my
actually
glass.
posted a bunch of questions.
Sure. Hang on, let me put my
Thank
glasses
you
on.
so much.
Yeah, go ahead.
Let's see. So one of the tests that you check for is lipid panel, I noticed. Just curious about like how to interpret that. Maybe you went over and I could have missed it. And then I want you to provide normal levels for the immunoglobulins. It's not something I do, but I have seen it being done by other providers, and I just like never really know how to interpret them. And like do just use the reference ranges that are provided by the lab. And then I think um the frat testing, I think recently, like I don't do a lot of it, but I am aware of it. Um, I've had a hard time finding folinic acid as a supplement form. And leucovorin is like it starts at 5 milligrams. So sometimes it seems like a really high dose for me. I just wanted to know, like, do you do something with that information if somebody comes back positive on that frat testing? And then lastly, I wanted to know if you have like a gut healing protocol, because I think you had mentioned Miraca, his DAO and cat's claw. But then, like that's not really in my mind like gut specific. I think it's more of like this neuroinflammation and maybe like reducing the histamine load and cat's claw I think is like an antimicrobial. So
Yeah.
those are my questions. And I did say like I really want to thank you for distilling all this information because I've been doing functional medicine for like 10 years and I used to be really excited about all the testing. And then it was just like me and I practiced with 5 other providers and we all kind of like started to do less. And I think especially with pediatrics, I think we're always like trying to simplify things because I hate giving them like 12 things for them to take. I mean, it's hard enough for them to take multivitamin, So I really appreciate you being the professor and just distilling all this information. So.
Oh, my pleasure. My pleasure. And first, that last point I think is so important because it's so easy to get caught up in the minutia, and it's so easy to get to a place where you think you need to fix everything. And I mean, just pointing the finger at myself, like I've been guilty of that. And, you know, even 4 years ago, even 3 years ago, I was still, when it came to mold toxins, totally into, well, let me fix every pathway there is because that's how I'm going to get these kids better. And before mold, it was like, let me treat methylation and let me treat, every dysbiosis that I see in the gut. And, oh, this thing is off, so I'm going to chase it with that. And one, I mean, that's a very quick way to run families away from you because they just get, overwhelmed and they're like, how the hell am I going to give this kid 15,000 supplements, right? Um, so I appreciate you bringing that up. And, the beauty of this model is because this entire distortion, if you want to say, affects so many different pathways and so many different processes. If you can nip the source of it, which is the gut, in the bud and take care of it, you will see a lot of other things just naturally restore themselves. I've had kids that had frank mitochondrial abnormalities on organic acid testing, like bad mitochondrial issues. The kid was sluggish. They had muscle fatigue. They would tire after running for 5 minutes. And I did nothing other than fix their gut. And 6 months later, like that kid is now an athlete. And I'm just standing there like, oh my God, this is just ridiculous. And if you really can get yourself into this mindset that less is more and get really, really, really good at just taking care of these core things. And that starts with knowing how to identify the issues that are there. I think the outcomes that you will start getting once you get it dialed in and figure out some of the nuances will be as good, if not better, than when you were doing a lot more. Um, so to touch on some of the questions you had, so lipids, I check lipids for two reasons. One, in some kids whose gastrointestinal tracts are just completely shot, they start having fat malabsorption. So one, with that comes vitamin A deficiency, vitamin D deficiency, et cetera, vitamin E deficiency. And then their cholesterol is in the tubes. Now, if you look at Quest and LabCorp, for whatever weird reason, they only have an upper limit of, total cholesterol. And it seems like every day it goes lower. And now it's like 170, 180, which I think is frankly a little too low for kids. But you'll get kids that have like a total cholesterol of 120, 130, 140. Those are the kids that you will have an uphill climb getting better quickly. Because one, they lack cholesterol that they need for, if you look at, for instance, the adrenal glands, where do all of the sex hormones come from? Where does cortisol come from? All of that is the adrenal glands takes cholesterol, right? It does a whole bunch of conversions and then spits out cortisol or these sex hormones. You need cholesterol for the lipid membranes, right, of the cells. You need cholesterol for the brain. So just that lipid panel can give you an idea of how well the gut is functioning, how compromised the gut is, and then also a barometer of how much success you can expect to have, how quickly. On the other end, you can also have relatively elevated cholesterol. Let's say not 300, where you need to send the kid to a cardiologist, but you've got a cholesterol of 220, 240. I suspect, I don't know this for a fact, and I haven't been able to find studies to back this, but what I suspect is when you have errors in fatty acid metabolism, because ultimately these fats and cholesterol do get utilized as, energy. And in some of the kids where I see that they have big errors in metabolism, I'll also see a cholesterol that's trending on the higher side. And I think that it's partially related to that. Let's talk about frat. So these folate receptor antibodies are a big deal, and they can influence cognition. They can influence neural functioning. There are a few companies that sell folinic acid in liquid form. They're hard to come by, but they're out there. I think Designs for Health has a superfolate, had a superfolate. But with leucovorin, so if you ever talk to people like Dr. Fry or Rosenall, those guys in 6 or 10-year-olds are pushing 15, 20. One time I talked to Dr. Fry, they were pushing 25 milligrams of leucovorin a day, which is insane. And I frankly don't have the guts to do that. In a little kid, even a 3 to 5-year-old, if they're stable, so again, not when they're inflamed, not when, they've got all kinds of sensory issues and sleep issues and anxiety and whatever, but you've put out the fire, their nervous systems are calming down. Leucovorin, which comes in a 5 milligram tablet, you can break that in half and start these kids at 2.5 milligrams, which in the world of autism and the world of folate receptor antibodies is actually really low. And one of two things will happen. Either after a week or two, it's like, oh crap, this kid is now having, panic attacks and anxiety and their sleep is messed up and whatever. Or, oh my God, this kid has started talking a little bit more. Or, oh, this kid's eye contact is improving. Or, oh, this kid is now able to, older kids can now focus better. And from there, you can start pushing the doses up. I cap out at 10 milligrams. That's the highest that I have the courage to go. But again, with some of these folks that have been in the community for a long time, they can definitely push the doses higher. And you can certainly make the argument that in some cases, if the kid has some of these things and you've addressed the inflammation and you've taken care of their gut, but their nervous system is still not firing, uh, addressing the folinic acid or folate deficiency could be part of that. You had one other question. I forgot what the other one was.
Let me see. I think I said, oh, like the normal range for the immunoglobulins, and
And
then
then the
do you have like a gut healing protocol?
thank you for the reminder. Um, so I followed the reference ranges that they give. The tricky thing is, so if you just do a serum IgA, IgG, IgM, um, you sometimes miss subclass deficiencies. So there are times that you look, you're like, oh my God, this kid has, very low IgA or IgG. Sometimes if you actually did a subclass analysis, which means they break it down into IgG 1, 2, 3, I think 4, and then with the IgAs, there's 3 of them. I can't remember all of them. But with the subclasses, sometimes you can have a subclass deficiency, but have a normal total level. But that subclass deficiency is enough to still muck things up. And when I do, especially the PANS doctors do a lot of IgG subclasses. I don't. When I see a kid who is really toxic and they have really severe issues, if anything, I focus on the IgA subclasses because those are the kids that need the greatest amount of gut support. They're the ones that you have to do the immunoglobulins and you have to do a host of things to get their gut to start normalizing. And those are also the kids that, at least for me, I set the expectation like, hey, mom and dad, do not expect an overnight fix. We've probably got 9 to 12 months ahead of us to get things to improve. And we just need to take our dear time. As far as the gut protocol, so, if you look at what's in Miraca, part of why I'm such a big fan of it and not things like Neuroprotect, which Dr. Theohaides came up with, which actually has more luteolin in it than Miraca, is Miraca, I believe, actually acts as a gut anti-inflammatory. So part of why it seems to work so darn well is you essentially get a two-pass effect. The first pass is it hits the gut, has an anti-inflammatory effect in the gut, and then gets absorbed and makes its way up to the brain, and then has an effect on the microglia in the brain. Both the PEA and luteolin are mast cell stabilizers. So you're actually getting a mild to moderate, depending on how you dose it, anti-inflammatory effect in the gut. And then when you add the DAO enzymes, those enzymes are predominantly working in the gut. And what you're doing is basically degrading the histamine that's in the gut that's causing the mess, it's causing that dendritic activity, disrupting the intestinal permeability. So those two supplements by themselves, even though we talked about it more in the context of neurocognitive issues and findings, when you actually look at their mechanism of action, they are gut immune modulators. And then if you add to that the oral immunoglobulins, the SBI Protect, the Mega IgG, now you have essentially a multi-front kind of gut support. And part of why I haven't gotten into everything else is I really want you guys to just start getting a handle on how these kids respond with these basic treatments and just play around with the dosing because I honestly, like, yeah, do I do more to support the gut? Yes. Do I do antifungals? Yes. Do I do certain other things to modulate the gut response? Yes. But these simple treatments, I'd say in at least 60% of the kids that you're going to see, and 20% of them being on the non-responding side are the kids that are just living in horrendous amounts of mold. Like at least above 50% of the kids that you've seen who have had mold exposure and have a tiny bit of mold exposure, but nothing horrific, will get better. And part of the importance of why I want you guys to get oriented to this is to start using these supplements as a diagnostic tool. Because yes, you can do a $300 test to look at neuroinflammation, but if you use the same supplements that you're treating, right, and the kids' OCD and anxiety and sensory issues come down by 50%, do you need a $400 test to tell you this kid has neuroinflammation? Probably not, right? And if the kid improved by 50% with just this first lobby of very simple anti-inflammatories, doesn't that tell you that the amount of neuroinflammation is actually pretty manageable? So the beauty of this conversation is if you get really good at identifying these kids and seeing how they respond, your treatments actually become part of your diagnostic workup. And then the need to do all of this other testing, at least in a majority of the kids, becomes less because you're seeing in real time how these kids respond, which then tells you how much more work you have to do, how disrupted their gut is, et cetera, et cetera, et cetera. Does that make sense?
Yeah,
Um,
and I think you're echoing kind of the practice approaches that we're all starting to adopt in my group anyway. So I do appreciate it. But and I totally agree with, all the like I used to do a lot of sensitivity testing for food, and then now I try to talk them out of it when they ask for it. I did a lot of gut testing, and then like just started to get to a point where I was like, well, I just don't know. I mean, maybe it's better to just like start them on some kind of a protocol and then see how things go. So I think the testing does become a lot less necessary. And then just following clinically, also just trying to like get a better sense of where should you start. And I did start doing a lot of oat testing, maybe starting a couple of years ago. So, because it just gives you like a place to start, I think,
yeah,
like a little
yeah,
bit more overview.
yeah. So let's see here. All right. So we had a question. Do you ever supplement with PEA and luteolin separately? I found elevation of terpenes have a good PEA. So you can, and I certainly would be open to any and all experience you guys have with other supplements. What I've what I found was finding a really good PEA is hard. Uh, and two, at a certain point, the ease of using a single supplement makes it worthwhile for the family. There are some kids, about 10, maybe, yeah, about 10% of the kids will react to Miraca. Is it the luteolin or the PEA? I honestly don't know. The majority of the kids, regardless of their sensitivity, tend to tolerate it pretty well. And I just got to a place where I did experiment with just PEA by itself, Neuroprotect, luteolin by itself. And the results that I was getting were not as good as using Mirica. And I don't know exactly where they're sourced their products from, but so far the efficacy has been really good. And even though I wish it was cheaper, I think it is a little pricey for what it is. Ultimately, the quality of the effect has been worth it. And if you guys get it from them wholesale, you can actually get it. I think it's 50% less than what they retail it for. And then if you want to mark it down and sell it directly, you can. Um,
Yeah.
so
I
the other question,
I was gonna say, I think cost is one barrier, but also a lot of my patients are young. And so just having the powder itself of the PEA, I suppose that some of them will open the Miraca capsules, but having it separately has been helpful. But I don't know. I don't know if it's gonna be as successful. So I will give you data points, and
please.
then probably find myself back at Miraca. But I got it from a local psychiatrist who's working on textbooks on this stuff, and I was like, well, maybe we'll give it a try. So I'm kind of
Please,
combining.
yeah. And
Um, I also snuck another question in there about the ALA panels because I'm starting to have a few of them come back. It was a little higher up, but I think it got buried. But wondering if you can help us with the interpretation of that, and maybe not today. We might be out of time today, but um,
yeah, so uh, for that, if you don't mind, post to the forums.
yeah,
I would love to have these discussions there. we're going to have more time specifically just, for each of you to present cases if you want. But in the meantime, just post it to the forums and be like, hey, here's the case, here's the result. What do you make of this? And I would be absolutely happy to comment over there.
Cool.
And then just as far as the texture of Miraca, one of the other reasons why I'm a big fan of it is almost every child, and I've got maybe 2% of the kids in the practice, mind you, like I get a lot of kids who have pretty intense kind of sensory stuff. Almost all the kids, when you mix Miraca with a little bit of juice, some of them even take it in water. You can put it in cold food. The texture of it is insanely well tolerated. So I would love to find the cheaper alternative. Like my biggest qualm with Miraca is I wish it was cheaper. But yeah, test it out and just let me know what you find. All right. So we had a question: how high do you titrate Miraca? And what do you do if someone reacts negatively to the nature DAO? So with Miraca, its safety profile is pretty insanely high. And if you go and look at luteolin and PEA, they're safe. Like all of the safety studies that are out there are suggesting that these are very, very safe products. So I think starting slow, especially early on, just so you get a handle on how well the kids can tolerate it and so forth, is great. But I mean, just to give you context, I just recently in the last month or two, I had 2 or 3 kids that were in the 6 to 8-year-old range, severe sensory stuff, anxiety, irritability. And I mean, for a, probably a week and a half, 2 week loading zone, I put them on 2 capsules 2 to 3 times a day. Um, and, in one of the cases, the kids got temporarily better and only flared. And it turns out they had a boatload of mold in their house. And then the other kid got better and then they titrated down and he was more or less holding. So you can really push these doses up. If you go back to what I presented early on, those dosing ranges are generally speaking very reliable in terms of the outcomes that you would get. And once you're feeling comfortable, feel free to double up and, do a week or two loading and really push and see what the supplement does. If someone reacts negatively to nature DAO, so the main reason why I see kids react negatively, and these are kids that either have disruptions in their sleep, they become more anxious, they become more reactive, is because their degree of HPA axis imbalance and adrenal imbalance is really high. So the nature DAO, the histamine digest, they don't really have anything in there that, at least immunologically, that I can think of that would be an issue. Whereas if the adrenal glands are already, really out of balance, and usually that's because they have a lot of mitochondrial issues. So on one hand, basically what the child's body is doing is using histamine to actually restore some degree of decent adrenal function, right? So there's a compensatory mechanism where their body is jacking up histamine and jacking up all of these different compensatory pathways to improve adrenal gland function. And then here we are, we come along, we're like, okay, we're going to fix that histamine because that histamine is causing an issue. And then the body basically just gives you the bird and says, no, 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 that histamine is there for a reason. And you actually get a compensatory reactivation of histamine that's usually a little higher than where it was before. And you'll see the same thing with antihistamine. Some of these kids, when they're put on antihistamines, they just completely become unglued. It's actually the same thing. What we have done, especially with something like Benadryl, is we have essentially messed with these histamine pathways. The adrenal glands get disrupted, so then the body recompensates. Those are the only times that I see that happen. Unfortunately, it's not that common. I'd say it's probably there 20% of the time. And if that's the case, sometimes carnitine can be really helpful to restore part of that metabolic functioning. In the treatment discussion, we'll talk about, using tinctures to support the adrenal glands. Doing adrenal support early on sometimes makes these kids worse because, again, there's multiple compensatory mechanisms in place. Now you've added rocket fuel to the adrenal glands, and then that becomes a problem too. All right. Roland said, having great success with Miraca and Histamine Digest. So if you guys are having positive outcomes, also post those on the forums. I think it'll be nice for you to encourage each other. So post your findings, post what you guys are seeing, and whether they're questions and you're like, I don't know what the heck to do with this case, or alternative, you do something, you're like, wow, this kid was doing so much better. Share that, because if anything, that'll encourage your colleagues to feel more comfortable. What indicators in the history of physical and lab testing do you use to treat with antifungals? The antifungals for me, so the biggest findings are, one, organic acid markers like tartaric acid, and various other fungal markers. Arabinose, I don't trust because just about every kid has elevated arabinose. The other thing is, at this point, I don't know if we can say if the elevations of the IgG antibodies through ALA-tests or some of these other labs is from gut colonization or from environmental exposure. So for me, once the kids are stable, whether it's nystatin or the more powerful, azoles, fluconazole, itraconazole, I pretty much empirically treat all kids with that, because part of what I've seen is, regardless to if I see a positive organic acid test or not, chances are these kids have fungal imbalance or microbiome imbalances driving part of the inflammation. And then specifically with the azoles, I am now pretty firmly convinced that part of why they benefit the kids is not just because they're getting rid of fungus and mold, they're actually acting as novel anti-inflammatories. So with some of these treatments, I'm not just using the pharmaceutical because I want to get rid of some fungus. So I'm using nystatin to first just clear the way, and it gives me a sense of how tolerant the child is. And if a child starts reacting to nystatin, and minus a very small number, maybe 20% of my kids where I feel really, really confident that they're stable, for the most part, I'll start every other child on nystatin. One, to start clearing some of the candida that's there, right? It's kind of fungostatic, primarily for candida. But in addition to that, and I've had a handful of kids where I was surprised, and the autistic child now is starting to make more eye contact, is now more engaged just with nystatin. But beyond the treatment side, I'm using nystatin as a way to essentially gauge and diagnose the degree of gut microbiome disruption that's there. Because if you treat with nystatin, whether you compound it or not, and that kid starts falling apart, and I think I shared in the prior presentation, like I've had a handful of my kids where I put them on nystatin compounded without many preservatives. 2 milliliters, they're fine. 3 milliliters, like all of a sudden they've got urinary frequency and they've got clothing issues, and now they're having panic attacks and they're falling apart. And those are the kids that if you dove right into itraconazole, like you would have created a complete disaster, because you have to stand back and look at all of the complex interplay between the fungi and the bacteria and how they're all interacting, and you disrupt any part of the microbiome too quickly, that will actually trigger an inflammatory response in of itself. And then some people make the argument that, as you kill off the yeast, they're releasing toxins of their own and they're releasing compounds which could be pro-inflammatory. So for multiple reasons, starting really carefully and then building up from there. And part of why I shared with nystatin to start is for those of you that can prescribe, that could be your way to start testing how tolerant these kids are. And then we'll get into a very detailed discussion around itraconazole and fluconazole later as part of that gut healing protocol. Did that help? Awesome. All right. Kate asks, what method for food allergy testing uh, do I do? So skin testing is great. And for the allergist, it's fantastic. You have to realize that if I remember right, the sensitivity of skin prick testing is about 80%. Sensitivity of blood testing is somewhere around 60 to 70%. For me, at the end of the day, when I do the food allergy testing, I just want to see if there's any big unknown allergens there. Because if the kid is eating, let's say, dairy or peanuts or almonds, and they have an allergy that we didn't know about, that is a really big problem. So identifying these big allergens and just taking care of them sometimes can make a big difference. And that's why. But I just use the blood testing and the skin testing. If you can work with an allergist, is great. I'm going to go all the way back. All right, so touched on this. Okay.
Can I maybe comment on that
Yeah.
allergy? Because I've run into that situation where IgE is elevated to certain foods, and I feel like I just want like maybe your input or other people's input or experiences. So the thought with allergists these days is if you can tolerate something that you're allergic to, then you wouldn't necessarily stop it because you're kind of risking anaphylactic reaction if you like completely remove it from their diet. So I guess from like my functional medicine training, I'm like, well, like it probably is causing some reaction in your body. So I think I just have developed some dilemma around it, and I don't know exactly how to counsel people around that.
So there's a guy named Interpol Randhawa in Long Beach, and he and I have a love-hate relationship because I tend to get, a whole bunch of, well, not a whole bunch. I've had more than a few of his patients that were kind of his non-responders. So I think the mistake that allergists make, while I do agree long-term avoidance of allergens is not a hot idea. In an acute inflammatory, if you want to say crisis or response, where mast cell activity is through the roof, gut inflammation is through the roof, these kids are completely falling apart. You can question the wisdom of continuing to provoke that inflammatory response in that at least short-term period of time, because if, let's say, a given food allergen or a food antigen is part of what is driving that gut inflammatory response, how the hell are you going to be able to heal the gut with that? Now, I say that with the understanding that, I've had some kids where I don't take them off all their allergens. So I get a whole lot of kids, like I mentioned, where they're actually going through a food allergy desensitization, except they're stuck. And the deal that I work out with the family is like, there are certain foods that they ate and they're tolerating pretty well, but whether it's peanuts or almonds or whatever the heck it is, every time the child eats it, they start having hives and runny nose or abdominal pain or itchy skin, which is an obvious and significant inflammatory response. And, their response is, well, just throw some Zyrtec and Pepcid and, whatever else. And, sometimes they'll get very clever and use cromolyn. But in these cases, your ability to be able to get that kid's gut to heal, I don't want to say it's impossible because nothing is impossible, but it's going to be really hard. And, what I tell the families is like, look, all I want to do is spend 3 to 6 months to see if we can get your kid's gut in a better place. And if your kid's gut is in a better place, chances are their ability to handle the allergens is going to be a hell of a lot easier. And there's one cute little girl that I'm taking care of where she is kind of, I don't want to say towards the tail end of treatment, but we're kind of in the 60-70% part of gut healing. She had God knows how many different food allergies. And at a certain point, even exposure to her high allergens was like, contact kind of uh, face swelling up, severe eczema, throat tingling kind of things. With the gut treatment that we have put her through, her dad is Latino and kind of macho, and he's like, I don't believe in any of this stuff. And they go out and like he'll let her take a bite of gluten, which she's technically allergic to, or give her a little bit of dairy, which she's also technically allergic to. And if this was a year ago, like that would have been like emergency room visits, kind of anaphylaxis. And now the little girl is like taking a bite of these foods, and at the very, very worst, like she'll itch like for 5 minutes without any antihistamines, and it'll stop. She'll maybe have a little tickle in the back of her throat for literally a minute or two. Again, no antihistamine, it'll go away. And part of, I think, what's so important about this conversation is asking why the hell have these allergies even come about, right? And if you go all the way back to the first kind of conversation around what happens in the gut, right? All of these things are really significant in driving this inflammatory response, whether it's the fungal imbalance, the mycotoxins, et cetera, et cetera. And as you take care of these things, the allergy reactivity will calm down. And then, if anything, the child's ability to handle their allergens and go through a desensitization improves dramatically. That makes sense? One of the last questions was, how high can you go with the itraconazole dosing? So if you follow, Dr. Sid Baker's lead and you look at the paper that they used, so they were, at least in the one case, they were pushing 600 milligrams of itraconazole a day, which like I don't have the stomach for, and you're definitely pushing toxicity levels at that point. I personally don't believe we need to go that high. Personally, I don't even believe you have to do daily dosing to get things to happen. If the exposure is taken care of, and I think this is the big difference, like if you follow Dr. Andrew Campbell, and he's one of my friends and mentors, and I adore the guy, he pushes daily dosing and has reported, wonderful success with that. What I don't see Dr. Campbell being obsessive about is the environment. You have to push much higher doses of these medications, and I think potentially have lower efficacy when the potential triggers for that immune response are there. Whereas I find with 5 per kilo, I typically max out at 100 milligrams, unless you've got some ginormous, teen who's, 150, 200 pounds, basically adult sized. I find at 5 per kilo, stopping at 100 milligrams per day, every other day dosing. And that's after I build it up. Usually I start like week 1, the kid gets 1 dose if they're really sensitive, maybe a dose every 3rd day to start. And then from there, building up to every other day dosing. Typically, the kids respond insanely well. And the kids that don't are the kids that typically have other things going on. And what you'll see me talk about, in the treatment presentation, these are the kids that I'm now exploring using peptides like lorazepam, KPV for, because those are the kids that typically, even at daily dosing, and I pushed it to daily dosing, typically, even then, they're not getting better. And part of the hesitation of doing daily dosing is, while if you have the ability to do follow-up liver enzyme testing to make sure you don't have liver toxicity, because that's certainly a possibility with itraconazole, there's a part of me, especially in the little kids, that just like my heart just gets sad for thinking of putting them through a blood draw every 6 weeks because we're pushing higher doses. So that's part of the rationale behind my approach. And again, you have to ask, like, what the hell is it that we're doing with itraconazole? Because I don't believe it's just we're decolonizing the gut. I don't believe it's just that we're restoring the integrity of the microbiome. In now experimenting on, a few hundred kids and playing with it on my own, what I believe now pretty firmly is itraconazole is actually first and foremost an anti-inflammatory. And if it's an anti-inflammatory, then you need to ask, like, is it the safest anti-inflammatory? Is it the best anti-inflammatory? And if the drug has certain side effect profiles that could potentially have impact on the child, and if you want to be really selfish, like your own, CYA kind of business, would you want to push those kinds of levels using it as that anti-inflammatory? And this is where, like in some of these kids, I'll just pour gallons of the oral immunoglobulins in. Like there are little kids that all push the oral immunoglobulins to a point of what they can tolerate orally, which is basically the kids just get sick and tired of the texture of, having this powder mixed into stuff. But you're still giving them, 1,500, 2 grams a day of the oral immunoglobulins. And I have yet to find one study that suggests that even at the higher doses, these oral immunoglobulins, if I can talk, cause any problems. So it's standing back and asking, like, why am I doing this? And what is the intention behind this treatment? And if the treatment works or does not, what is that treatment telling me? Does that make sense? All right. Any other questions? Yeah.
When people have no tolerability for the Miraca, is it mostly just they're taking too much powder in, or is there kind of a subset of symptoms that you tend to kind of see and go, up, those people aren't going to tolerate it versus someone else?
So I found that the kids who are the most inflamed, the kids who really are the most toxic, are the ones that may not tolerate it. Fortunately, they're far and few in between. And really how the intolerance shows up is they start having worsening anxiety. They have more irritability, more OCD, more aggression. And it shows up fairly quickly. Like, it's not you give it for years and the issue shows up. You give a few doses and within day 2 to 3, they're reacting.
Okay,
That help?
thank you. Yeah.
Anything else?
Dr. Pejman, I'm excited to see you in Orlando this weekend.
Yeah, excited to meet you in person. Yeah, it'll be fun. There's a wonderful lineup for you guys. This is the Documenting Hope conference, and it's the speakers that are there are going to be remarkable. But yeah, look forward to meeting you in person. All right. Have a lovely day, everyone.
Good night.
Good night.